Hi all, I'm going to cover a most important topic in neurocritical care. That's a subarachnoid hemorrhage. Now, why it is so much important? Subarachnoid hemorrhage is associated with significant mortality and morbidity. Now, it's the mortality is very high. 12% of patients that die before reaching the hospitals. Now, rest, 88%, 25% patients die in hospital, despite of getting the best hospital, the best medication, and the best quality of care. 25% they succumb to death. Remaining 50% patients, they are left with significant neurological deficit. So it is utmost important to diagnose early to provide the treatment. I'll start my discussion from a case. A 50-year-old female patient was doing a preparation for the children for to go to school. Suddenly, she experienced some headache, which was severe enough. Now, she is a known case of migraine, and she thought probably it is a migraine attack. She took some over-counter some medicines, and she felt it is fine. That subsided only for a few hours, again to reappear as a thunderclap headache. Now, these are all the typical presentation of subarachnoid hemorrhage. Now, once you encounter this kind of patients, you need to be of like very alert enough to suspect a subarachnoid hemorrhage and to work out on that line. Now, second, how to approach to a case of subarachnoid hemorrhage? Whenever you suspect a case of subarachnoid hemorrhage, urgent diagnosis, urgent suspiciousness, and urgent diagnosis is the paramount importance. Now, once you diagnose, then go to assessment of severity, then etiologic workup, then you need to diagnose whether it is a aneurysmal or a non-aneurysmal subarachnoid hemorrhage, because the treatment vastly varies in case of aneurysmal versus non-aneurysmal. Early aneurysm repair, if it is a aneurysmal, or you have to at least stop the bleeding if it is a non-aneurysmal subarachnoid hemorrhage. Now then comes, you need to anticipate the complications and treat the complication or avoid the complications. Then the course of, on an average, this course of subarachnoid hemorrhage patients may vary from 2 to 3 weeks, and the course may not be smooth as you expect. It may be very turbulent. You need to be war-footed to detect these patients. Now, coming to the risk factor, who are the patients who are on the utmost risk for developing a subarachnoid hemorrhage? Smokers, patients with hypertension, particularly untreated or unregulated hypertension patients, elderly patients. Usually, children are the very few cases of SAH detected in younger patients. Alcoholic, female, because of unknown reason, female sex groups, they are more vulnerable. Now, patients on sympathomimetic drugs. So it is paramount important to take a drug history if a patient you are suspecting or you have detected a subarachnoid hemorrhage. Now, coming to the little bit of pathophysiology. Now, size as well as site, both are important. Now, size is important because size determines the occurrence of hemorrhage in an aneurysm. Smaller aneurysm like 2 to 7 mm, they rarely bleed, but a bigger like more than 10 mm or 10 to 24 or more than 25 mm size diameter aneurysm is called a giant aneurysm. They will have a very high risk of bleeding. Now, coming to the site, particularly distal ICA to posterior communicating artery, that is the most common site of bleeding. 41% of aneurysmal bleed happens in the distal ICA and the thecum junction. Now, intercommunicating artery to junctions, that is 34%, 4%, MCA territory 20%, and vertebrobasilar, it's the rarest site, that is the 4% of aneurysm do happen in the vertebrobasilar territory. Now, coming to the diagnosis. Now, the fast and the most sensitive diagnosis is a non-contrast CT. Now, sensitivity is 100% if you do early. Now, this classic CT looks like this in a patient. Now, coming to the second diagnosis, the lumbar puncture. Lumbar puncture is needed if you have done a CT, you are having a high suspiciousness, and your patient and your CT is normal, then you can go for a lumbar puncture. Now, what are the findings you can find in a lumbar puncture? Elevated opening pressure, xanthochromia, and elevated RBC count. These are the classic finding in a lumbar puncture if your patient will have the subarachnoid hemorrhage. Now, coming to MRI, okay. Usually MRI is not the first line of diagnosis, but if you have done a CT, you are inconclusive, then you can go for a flare, diffusion, DW1 or a gradient MRI. Now, the diagnostic pathway is the first and foremost, you subject the patient to a non-contrast CT. If it is positive, then the next comes the perfusion CT or a CT angiogram that will give the clue of the size and the site of aneurysm that helps in the surgical repair. Then comes the DSA. Now, once you detect, then the finding the etiology is most important. Okay. The risk factor for aneurysm, if it's a larger, now you have to detect the size, morphology, site of aneurysm. Those are most important. Now, next comes the severity classification. There are 3 to 4 grades of classification. One is the Hunt and Hess classification. Second is the FSN classification. Now, the FSN is used more frequently than Hunt and Hess classification. Then next comes the Fisher classification and the modified Fisher classification. They are the city grading classification for vasopressin. But for exam going students, do remember Hunt and Hess is the severity or the outcome assessment scales. Fisher and modified Fisher are the assessment are to assess the vasospasm in a patient. Now, the most important part of my talk is the management. Now as a intensive care physician, so what are the areas of paramount importance for an intensive care physician? It starts with the airway management. Now, airway, these patients may come to you with a compromised sensorium, compromised airway, compromised breathing. Okay. Now, airway maintenance is most important. Then comes the hemodynamic and neurologic monitoring. Okay, that is most important. They may come to with hypertension or hypertension. So BP, there are target BP to maintain. Like there are different targets before aneurysm repair versus after aneurysm repair. I will go in the next slide. Then keep the patient comfortable, rest, stress ulcer prophylaxis. Avoid any aggressive like high grade fever or pain in this kind of patient. Then glycemic control is of most important. Now there are some non-neurological complications which you need to be fully aware and you need to be alert enough in these patients. Now, subarachnoid hemorrhage is called as pancreatitis of CNS. So the complications can involve from head to toe. Now, to start with the lungs, they can suffer with a pneumonia like neurogenic pulmonary edema, aspiration pneumonia to ARDS. Now, you need to be alert enough to suspect and to detect these complications in these patients. Now, cardiac complications, myriads of classic cardiac complications starting from the benign ECG changes to tachycarditis or myocardial infarction is also documented in a patient with subarachnoid hemorrhage. Now coming to the kidney, these patients are highly vulnerable for acute kidney injury, then metabolic derangement, hyperglycemia, then hyponatremia and hypernatremia, both are documented. Now hyponatremia is more common. If it is hyponatremia, then it might be because of the SAH, which is very common in these patients versus a cerebral salt wasting syndrome, which is less common. Now, if you encounter a hyponatremia secondary to the SAH, then the rule is maintain a normal volume. Do not restrict fluid in these patients. That may be catastrophic. Now, if it is a cerebral salt wasting, again, you need to give volume. If it is a diabetes insipidus, again, the treatment is to maintain the volume. Seizure, the most important risk factor in this, the risk is the seizure. Okay. So who are the patients who are going to develop seizure? There are high risk entities like a thick subarachnoid clot, a intracerebral hemorrhage, a delayed impact, or aneurysm if it is in the MCA territory. They are particularly vulnerable for seizure development. Now, once they develop seizure, you have to start management, then anti-seizure, then anti-epileptic management, then magnesium sulfate is tried, but there is no conclusive evidence. Now, after seizure, then comes the vasospasm. Okay, that is again the second most dreaded complications. Nimodipine is having a proven role. Okay, they decrease mortality. So now there is a standard dosing for the nimodipine that comes. The dosing now. The dosing is 60 milligram 4th hourly nimodipine. You have to go. That is a standard dosing. If patient develop hypertension, then you have to decrease the dose. Then second, other complications is like a rebleeding. So if the complication you are encountering from the first to third day, then two complications are more common, which is one is the rebleeding, second is the acute hydrocephalus. If your patients develop acute neurologic deterioration within third day, these are the two documented complications you need to be alert enough. Now, if a patient develops some neurological complications from third day onwards, then delayed cerebral ischemia is a known entity. Now, under management of the secondary complications, your rebleeding, if you are suspecting a rebleeding, then surgical, the management start from the surgical management to the medical management. Like early repair of aneurysm, then in between aneurysm repair, okay, there are two documented methods. One is the clipping and endovascular coiling. In your exam, it is very specifically asked. Now, I will answer a little bit. The recent trial, that is the ISCCM trial, it is a multicentric RCT. Now, they documented endovascular coiling is superior to clipping in this patient, but people with larger aneurysm, that is more than 8 mm, with IC bleed more than 50 ml or a MC aneurysm, it is better to go for open surgery, that is clipping, compared to endovascular coiling. So these things you need to remember. Now, under medical management, then comes the tranexamic acid, it's having its role. Now, second to the hydrocephalus. If a patient develops hydrocephalus, then initial medical management, then start with the EVD and the anti-edema measures. Now, how do you detect a delayed cerebral ischemia? Now, the TCD, first is a neurodeterioration. If a patient deteriorates neurologically, then you need to do a TCD. In TCD, two things you can detect. One is the velocity of MCA, if it is more than 120. Second is the Lindegard ratio, that is the MCA velocity to the ipsilateral ICA. If it is more than 6 Lindegard ratio, then you have to suspect a cerebral vasospasm. Now, hemodynamic monitoring, the classic teaching of triple H therapy is no longer it is recommended, but out of these 3 H, hypertension is still having its role. That the post repair, that is after clipping or coiling. Now, hemodilution and hypervolemia is no more practiced in these patients. Now, this is the last slide to conclude. Now, the success of a subarachnoid hemorrhage maintenance depends upon the early diagnosis, early suspecting, and to undergo a early CT and early repair. Second, assessment of severity. You need to assess the severity precisely. Mild, moderate, and severe group. Severe group need to be treated in an expert center where there are high volume cases are undergoing. Then a etiologic workup. There should be a flow diagram to maintain these patients. Then suspecting the early complications, avoiding complications, preventing complications, then managing the complications once they develop. The course usually may not be that smooth. It might be a turbulent course, but you have to have patience for these patients and may succeed in managing subarachnoid hemorrhage if you maintain them up to at least 2 to 3 weeks. So this is the end of my talk. Thank you for patience hearing.